Thank you, Dr. Fader, and thank all of you really for your statements. Now, the way we work it, we have questioning now from members of the committee, and I'll start by recognizing myself for 5 minutes. And my question really is to both Dr. Reinhardt and Dr. Fader. I'd like to get your thoughts on the addition of a new public plan, which you actually did discuss, a new public plan to the menu of healthcare tools available for expanding coverage. Obviously, we want to build on existing programs like S-CHIP and Medicare and Medicaid, but the fact remains that with 46 million uninsured people in this country, we will need to build significant new capacity in our insurance system. Now, you know, we've talked about having the government do a healthcare marketplace. Massachusetts is sometimes cited as an example where the government would go out to private plans and, you know, see what their benefits are, their premiums, perhaps negotiate both those standards and premiums and offer group plans to people as an alternative to the individual market. But in the context of that, is this possibility of an option to enroll in a new quality, affordable public plan? And the goal of that would be to create healthy competition with private insurers, lowering overall costs and at the same time expanding access across the healthcare system. So I wanted to start with Dr. Fader and ask what you think about creating a new public plan, and is that a good idea in the context of some kind of health marketplace, national health marketplace?
Mr. Chairman, I think you've posed the question exactly right. It's very important to remember that what you've put forward and what's being talked about is a choice for Americans, and choice of private and public plans, not characterized as a public takeover or Medicaid for all. That's completely incorrect. We're talking about choice. And the importance of that choice is actually to set a model. Insurance companies are no model for running this system efficiently, private insurance companies. And they are not getting us good deals and getting us adequate protection. So establishing a public plan that is a choice and that operates on a level playing field with private insurers can actually serve as a push to get more competition. I think competition is a goal that all of us have, effective competition to get efficiency in the healthcare system.
Okay, thank you. Dr. Reinhardt, do the experiences of other countries that have successfully built universal healthcare systems suggest that a new public plan could be helpful to America, to the U.S.?
I think certainly it could. Not a lot of countries actually have this sort of mixture. The only one that comes close is Germany. They don't really have a public plan, but they have privately managed sickness funds, nonprofits, that work a little bit like Medicaid managed care, where the government collects the taxes, essentially, but lets private competing health plan purchase the health care, but under unbelievably tight regulation. So it almost is like a government plan. I, too, share the view that if choice is the mantra, and many Americans really do like choice, then having a public plan that people might like seems to be something that should be done, because by what rights would one deprive the American people of a choice they might favor? Now, where would I get this idea that they might favor a government plan? Well, two. The first one is we do have Medicare, and the elderly have a choice to go into private health plans or to stay in the government-run plan. And I don't know what I think 75% still choose the government plan in spite of the fact that the private health plans the taxpayer pays them 14% more to be able to offer a benefit. To me, that suggests there is a strong latent demand among the American people for a private health plan. And then people say, well, that's socialized medicine. And I would urge the committee not to use that term anymore. And the reason I do is I'll tell a little vignette. People will tell me, oh, socialized medicine is just terrible and it's awful. Now, I always say, okay, I'll accept it. Why do you not like my son? And then they look, what have you got to say about my son? I said, my son is a veteran, a decorated U.S. Marine Corps veteran with a Purple Heart. And yet you give him socialized medicine called the VA. So why do Americans run down this concept of, we're not even talking socialized medicine, we're talking about social insurance run it down and yet give the very contract to their veterans, and I am a father of one. And I'd like sometime if somebody in this room write to me and explain this paradox to an immigrant like me. Why do you give veterans socialized medicine when it's so bad?
Thank you. Mr. Deal?
Thank you, Mr. Chairman. As I indicated in my opening statement, transparency of pricing is important to me, and I have introduced a bill, and I'd like to give you some of the components of that and see what your reaction to it would be. First of all, the bill would allow uninsured patients and other patients who pay out of pocket for certain health care costs to be able to go to an HHS website, enter their family's income and the health care services they need, and find out the prices they'll be charged for these services by all of the health care providers in their area. Second, it would allow doctors and hospitals to use the same website to find out what a particular insurance company will pay them for a particular item or service before it is delivered, and it will allow these providers to find out what their patients' copays will be. Third, it would allow the insured patients to make better informed decisions by allowing them to use the same website to find out what their copayments would be for particular health care services in their area, depending on who the health care provider was. And finally, it would require HHS to publicly disclose all of their Medicaid data in a way that protects individuals' privacy, but allows the public to join in the fight against Medicaid fraud and allow patient advocates to make sure that Medicaid patients, for example, are getting the care that they need. It would allow citizens to know whether or not young children who are enrolled in their state's Medicaid program are getting their well child checkups, and whether older patients are getting their annual cancer screenings. Would a piece of legislation like that be something that each of you might support? And I'll just ask you individually. Dr. Reinhardt?
As a general principle, price transparency is essential if you ever want to have models based on choice and competition. And of course, the health system has been uniquely opaque in this regard. Now, there is a problem with posting prices. Hospitals' charge masters have close to 20,000 items in it, and a physician fee schedule has 7,000 items in it. So prices would have to be reconfigured to be 4 complete procedures. I had in a paper proposed in Health Affairs that maybe the way to go is to say, let us use the DRG system for all patients, no matter who the insurer is, because it is a relative value scale. But each hospital has the right to set its own conversion factor to monetize the thing, and they have to advertise that. Then only one number would give you the prices of a hospital. Or one could have research that bundles all the services that go into a treatment like a coronary bypass graft or a hip replacement, and then give you the price per procedure with everything bundled in. But I think the idea of transparency is one I would wholeheartedly support.
Thank you. Ms. Pipes?
Yes, and I, too, support price transparency. We have price transparency in most aspects of our life, whether it's what phone service we use or what bank we use. I would be against government mandating price transparency. I think, in consumer patient-centered health care, we've seen we will see, if we encourage that and support it, I think we will see price transparency, because when you put doctors and patients in charge of your health care, prices will be negotiated. I think if we change the tax code, as I mentioned, so that individuals can buy health insurance, as Ms. Eshoo said, on the same level playing field that those who get the tax benefit through their employer-based coverage, I think we will see much more competition. We will see new entrants into the insurance market, and when we have more competition, we will see prices being negotiated. I think even in Medicare, we could open up to empowering Medicare patients and doctors, and we will see people negotiating, and we will get price transparency as we have in all other aspects of American life.
I take that as a qualified yes.
Yes. Yes.
Dr. Fader?
I think that your proposal, Congressman Deal, makes a great deal of sense. I haven't seen it in all its details, but the transparency in getting inside the black box of insurance is critical as a customer, as a taxpayer, every other way. And so I applaud your efforts, and I'm happy to be of what help I can.
Thank you. Let me explore very briefly, because my time is running out. If we go to a government option proposal that would be offered as part of a package, would you anticipate that that government option would also have to take into account state mandates on what must be offered, which vary obviously from state to state, and would it also therefore take into account community pricing? And if it does all of that, don't we wind up with a system where a public plan would cost significantly more depending on where you lived? And how do we deal with that inequity in terms of explaining that to the public? Or would it simply be a uniform premium that you would anticipate that public plan would offer?
So I pointed that out in my testimony, that things like guaranteed issue, community rating, and a lot of mandates add significantly, 20 to 50%, to the cost of a premium. And if within this national insurance exchange there is going to be a public plan and all of those things are going to be added onto it, you're right, we're going to see the cost of insurance go up rather than going down, and that is going to crowd out more people out of getting covered and reducing that number of uninsured. So I would, under the health savings account, patient-based health care, it's not for everyone, but we have seen prices come down, as Mr. I think Burgess mentioned. We've also seen that people who have HSAs are 30% more likely to get an annual checkup and be engaged in prevention because they don't want to be facing significant costs once they have a degree, and that work was done by McKinsey and Company. So I think we have to be very careful. I'm very worried. New Jersey, New York, Massachusetts have community rating, guaranteed issue. Their insurance is very expensive, and if we do this plan, it's going to crowd out private insurers, and that's my main concern.
I'm sorry, I can't have any time. I've already exceeded my time, and I'm afraid I can't let the rest of you answer, but maybe we can get to it later. Thank you.
Thank you, Mr. Deal. Ms. Eshoo?
Well, I want to thank the witnesses, each one coming from their own place and stating their case really forthrightly. I enjoyed your testimony, and I think that while I might not agree with everything that I've heard, I like the way you have framed it and presented it to us. Since today is St. Patrick's Day, and the one day where we're all Irish, Ms. Pipes, or is it? Yeah, Pipes. You quote P.J. O'Rourke, and you say, if you think health care is expensive now, just wait until it's free. Where in anything is anyone talking about free?
Well, Michael Moore...
I mean, where does this come from?
Well, because people, like as Michael Moore said in his movie Sicko...
No, we're not talking about movies. We're talking about reality.
Right.
So when you say in congressional testimony, if you think health care is expensive now, wait until it's free. Who has suggested that health care is free? We are faced with 12 and 14% increases every year. It simply is unsustainable. We know that people are left out. We know that it's a system that's fractured. We know that we're spending too much as a nation and not getting back for people what they should have. And so I really think that the notion to say just wait until it's free is, it really doesn't belong here. I feel strongly about that. I don't know if you might not regret having said it, but I don't think it's really part of this. Now, I mean, you can defend it, but
Right.
do you have a defense for it?
Yes, sorry. So
Yeah.
thank you for that comment. The reason, what it means is when government takes over the supply of health, the total supply of health care, people think it's free because they're
Well,
not
we can
paying
get into a
directly.
real debate here. This is not a discussion about the government taking it over. This is about the government rewriting the rules of this because so much of it is not working. And we know that it's not. Insurers say that. Families say that. And so there's consensus on that. So now, let me move on and just ask a few questions. I really want to kind of drill down on this whole issue of tax treatment. And while this is not the Ways and Means Committee, you're all experts, and I really would like to hear your views on this. And what your opinions are on the tax treatment of employer-sponsored insurance plans. As you know, those who get their insurance through work pay no tax, while those that purchase insurance without a group plan do. Do you think that all plans should be taxed? Do you think they should be taxed in part for certain services? What's your view on all of this? It's not a subject matter that's often discussed, and I'm curious about it. So, Dr. Fetter, do you want to start?
Sure. You raised it in your opening
Right.
remarks. It's concerning to you, and our employer-sponsored health insurance has grown up. And the development preceded the special tax treatment, but that has strengthened it. And there is a concern about inequities because better-off people get a better break than
Right.
low-income people, and certainly than low-insured, because it varies with your
Sure.
tax bracket. And so there are concerns about that. But I am very concerned about doing anything that undermines the employer-sponsored health insurance system, because although it's got significant limitations, it does create the groups. And you talked about assuring access to group insurance.
Right.
It creates those groups that enable us to pool risk rather than having everybody on his own, which we see in the non-group market. So I think that there are concerns about it. I think as we develop a system, we want it to be fair and shared responsibility, whether it's through the tax system or other mechanisms for everybody. But I am very concerned about proposals to eliminate the tax break, because it essentially does undermine the insurance system, the employer-sponsored, and also anything that would shift, that make it come apart and throw everybody into the non-group market.
Thank you. Dr. Reinhardt?
Well, almost.
Oh, you
most-
posed a question about socialized. It's a political phrase to scare people.
Yeah,
That's what it is.
yeah, but it's
It's a bumper sticker.
it's really peculiar when you
It is peculiar.
when you're the father of a veteran to have that.
Well, how about members
a
of
bad
Congress
thing.
receiving Social Security?
Yeah, or that,
Yeah,
or bankers.
right.
Who are on Social Security, as
Right.
you know. No, the issue of taxing employer-provided benefits, most economists, in theory, would be for that, but there's always the concern, and I've written a paper on a balance sheet for employment-based insurance. At the moment, it's the only really functioning risk pooling mechanism in the private sector, and actually, for all its flaws, has worked. It served Americans reasonably well. So an alternative might be to go and say, well, self-employed people should have the same tax privileges. I don't think tax-wise it would cost that much money, and that seems fair to do. But there still is an issue of giving people in high-income brackets a bigger tax break than in low-income brackets, which you really sense with a flexible spending account, where when I get a tooth drilled, it costs me half, and a gas station attendant pays 85 cents on the dollar. So there are ways to deal with it. For example, one could say, harvest some of the money. I'm a full professor at an Ivy League university. I really don't need this tax break to get health insurance. I could be asked to pay taxes on it, and I think I would. So you could say if you're making less than $75,000, you won't be taxed on it. If you make between 75 and maybe 150, we'll take half what the employer pays and add it to your W-4. And if it's over 150 or over 200, the whole thing is taxed. Then you say you're punishing the rich. Well, I don't consider that punishment. I consider asking me, who is so lucky to have a tenure job at Princeton, to pay for my own health care. I don't call that an imposition. I don't really need that subsidy from the gas station attendant, which I now have. So that is one way you could harvest some of the money without hurting the rank and file.
Thank you very much to each one.
Gentleman from Kentucky, Mr. Whitfield.
Thank you very much, and thank you all so much for your testimony today. We appreciate it very much. When we think about Medicare, Medicaid, the VA, S-CHIP, we know that represents about 48 or 49% of the total health care delivery system in the U.S. And we view those, I think most people view those as government programs, which is providing a valuable service. But we also know that those programs are contributing greatly to the escalating cost in health care. Every time you visit with the Concord group or a lot of groups, they say with Medicare increasing cost every year and Medicaid increasing cost every year and Social Security increasing cost every year, that we're going to have a financial disaster 22, 23, 24 years down the road, on top of our already economic crisis that we face today. So when we talk about reforming health care, I think many of us on this side of the aisle view it as the government taking it over. I mean, and the government already runs Medicare, Medicaid, SCHIP, the Veterans Health Care System. And I know, Dr. Reinhardt, you mentioned that I think I had to leave during your testimony, but I think you said we need universal health coverage. And Dr. Fetter, I don't know that you said that, but I believe you set out certain principles that you had to consider to
And I do favor universal coverage.
Yes. So if the government plan that's in operation today, I mean, the ones that I mentioned, the costs are escalating every year, and we can't control those costs. If we allow government to be basically responsible for the other 50%, why are we encouraged that that government could control those costs better than the way we're controlling costs today?
Well, Congressman, I don't think we are proposing having government take over those other costs. And I actually think as you look at the share that government is spending, some talk about it as shifting from the private sector to the public sector, because our public programs are taking care of older Americans, disabled Americans, and Medicaid. The bulk of the spending in Medicaid is for people with disabilities and older people and long-term care. So they have particular responsibilities and have left the healthiest population to the private sector. And when you talk about the overall cost growth, we have lots of evidence, and I know that former CBO Director Peter Orszag presented that to you as CBO Director, and now as OMB Director, he makes the same point, and that is that our public health insurance programs are not growing faster than the cost of health care in general. Everybody's buying in the same market, although Medicaid really buys on the cheap. But the costs are growing in general, so that the only way to get a handle on the growing costs, which you rightly recognize, of Medicare, Medicaid, veterans, any health insurance program that we have, is to pursue slower cost growth through investment in primary care and prevention and a host of other mechanisms that affect the entire system, and to make sure that everybody's got coverage all the time so that we can promote prevention and better treatment.
Now, you know, as you were talking, and Dr. Reinhardt, I'll give you an opportunity to reply also, but as you were talking, another government program that I think has worked very well is the community health centers. I mean, I think the community health centers addressing the primary health care issue have worked very well, and basically they're paid for by the federal government working with local entities. And I always thought that community health centers are in a partnership in the private sector with gigantic employers might be a way to expand accessibility too.
Well, I share your view of the excellent performance and the value of community health centers, and they certainly are a part of the system in making sure that, as many have said, people don't just have access to health insurance, they have access to care. But the community health centers, unless people have insurance coverage, they face tremendous problems once anybody gets beyond private primary care. They can't find specialists. People need insurance coverage.
Now, Dr. Reinhardt, if you'll take about 30 seconds to reply, if you can, then I want to make one other comment.
Yeah, the first point I want to support, if you look in November '07, Peter Orszag published a beautiful report on health care cost growth. And there's figure 4. You can actually really see how each sector, public, private, is growing. And in fact, on a per capita basis, Medicare has grown less rapidly than the private sector. On the community health center...
On the cost of it?
On the cost. Okay. You have to do it per beneficiary, and Marilyn Moon has done a lot of research. And that's well understood. On the community health centers, I think they are an important part of the landscape in American healthcare because they're so accessible, and they do a great job for the money they have used. But we had a commission on rationalizing New Jersey healthcare, and looked at these centers, and this theme that they are great in primary care, but then they're not multi-specialty. Getting access to specialists was the Achilles heel. So yes, I think we should have them. They should stay, and the Congress might worry about how to have a larger range of services provided.
Right. Mr. Chairman, I would just make one other comment. Another thing that bothers a lot of people, though, when you talk about universal health coverage and you think about the Canada system and the Great Britain system and so forth, and Ms. Pipes went over this in her testimony, maybe you all can address it later, but if it is true 750,000 Canadians are waiting for procedures, and 3.2 million out of the population are waiting to get a primary care doctor. And Canada, average wait for seeing a primary care doctor for getting treatment by a specialist was 17.3 weeks. And the rationalization of health care, that is a real concern to a lot of people. And you can't respond to it now, but later on, I'm sure we'll have an opportunity to address that in more detail. Thank you.
Thank you. Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. And following up on my colleague from Kentucky, I have a district, a very urban district in Houston. It's an underserved district. We have actually 4 community-based health centers, and they're in financial trouble right now because so much of that we depend on is foundation funding. And foundation funding, because the economy is cratering. So we need more of them, but we also need to look at our authorization levels. That we upped the authorization, our 5-year authorization last time. Even with the stimulus money that was in there, in the Houston area, the 4th largest city in the country, it helped 2 of our FQHCs. So I don't, that's, we need to do better on the community-based health centers, and hopefully whatever plan we have will make them where the rubber meets the road, literally, for the uninsured and the underserved. I mean, it's a great program. It's been around for almost 50 years now, I guess, since President Johnson. And I'd like to ask the panel that how do you see these FQHCs because of the, my problem is the disparity of the location. Great example, Chicago is fortunate to have 81 community health centers, and in Houston, Harris County, we have 10. And we're trying to create more, even though we're the 4th largest city and may pass Chicago in the census. But how do we create, we have a disparity in where these centers are located because of the local networks.
It seems to me, Mr. Green, and I'd have to look into it further as to what the problem is under the current circumstances, but the best way that you can promote those delivery systems is to get everybody health insurance, because then every patient who comes into a community health center is carrying money. They're not dependent on a federal grant. So the bottom line is that we need health insurance in order to enable delivery systems to prosper.
Well, and the problem FQHCs have is just like problems hospitals and doctors. You have a lot of uncompensated care.
Exactly.
Even though people have to pay something, they don't pay enough that covers the cost of the
Right,
service.
and valuable as they are, and as Mr. Whitfield said, is that even expanding community health centers is not a substitute for getting people insurance. They're a valuable part of the delivery system and should be supported by everyone having health insurance coverage.
I'd just like to add that I support community hospitals, and Michelle Obama, during the campaign, said, being at the University of Chicago, people shouldn't be turning up at the University of Chicago emergency rooms for very, very expensive care. She supported the community hospital. So that was a very good point. Just on a point on the hidden tax, people keep saying that the uninsured are adding a tremendous burden to the cost of those who have private insurance. The work done by Dan Kessler at Stanford, he shows that the uninsured are adding about 1% to the cost of premium for those who have private insurance. The 10% cost addition to private payers' premiums comes from Medicare and Medicaid, from the lower reimbursement rates paid by the government. So I think that we really need to focus on, how if we're going to go down the path to more Medicare, more Medicaid, expanding these programs, reimbursement rates are low, and as we see now, 1 in 3 new Medicare-eligible patients is having trouble finding a primary care doc. Because in systems like Canada, when the government took over the health care, people talk about there'd be a lot of increase in primary care. But in fact, med students didn't go into primary care because when the government determines how much you're paid, they would rather go into specialty. So that's why we have a tremendous shortage in Canada of primary care docs.
Well, I'll give you an example, though, that FQHC's doctors can make a decent living there. You know, you can get $135,000 or family practice in a community-based health center. The problem is it's not, you know, not the specialties, and we know how high the specialties are. Dr. Reinhardt?
I would want to stress Dr. Fader's point. The important thing is to endow people with purchasing power to get health care. Because the trouble with institutional grants is you can have community health centers that are angelic, they have this budget, and you have others that are not. And to get performance is measured is not easy. But when customers can walk, competition will actually take care of it. That's why, in general, community health centers as a delivery device are good. But I think it would be good that if their clients brought their own purchasing power with them. On this issue of cost shift, this is actually an interesting thing. People who believe in markets should not believe, in my view, that just because Medicaid or Medicare pays hospitals too little, private payers have to pay more. That's not true in a hotel. If somebody gets a discount, they don't call you up in the middle of the night and say, hey, Smith just registered. We gave him a discount. We're going to raise your rate. So if you actually believe the private market works, why are private insurers not following Nancy Reagan's advice? Just say no. Well, we're not going to take it. So I don't believe this cost shift story of private payers picking up what Medicare doesn't pay. I don't believe in that story.
Well, Mr. Chairman, I know we have a situation in our country. Medicare pays so much, Medicare actually pays less. Mm-hmm. But in some cases, if you have a military base, you ought to see Champus and TRICARE don't even pay what Medicare makes in reimbursement. And we've run into that problem in a very urban area with our number of activations. So you're right. We need to look at the reimbursement rate to make sure they actually do fit the cost of the service. Thank you, Mr. Chairman.
Thank you. Gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. Let me just ask a question. I hate to do this because it's beyond the scope of this panel, but Mr. Green brought up in his opening statement that Texas has 25% uninsured. When Massachusetts did their program several years ago, they made a decision that they were not going to factor in, or they were not going to include in their factoring any cost for people who were in the country without the benefit of a Social Security number. Of the uninsured in Texas, there are a significant number. We could never ignore that number of people who are in the country without the benefit of a Social Security number. So we failed on several attempts since my short tenure in Congress to deal with this issue. Can we really get to the point where we're talking about the type of reform that you three are discussing if we don't deal in some way with the problem we have with immigration and people who are in the country, again, without the benefit of citizenship?
Well, I served on the board of a Texas-based hospital company, and we had this very problem. On the front lines, you cannot tell when people come in bleeding or pregnant about to deliver. You cannot send them away. So we serve them one way or the other.
So in fact, you're required to under federal law, under EMTALA.
EMTALA, yes. And in New Jersey, it's even more. The whole thing has to be delivered. So most of the immigrants are actually working or have families where somebody works. And it seems to me we have let employers in this country off the hook much too easily. They should pay for the social services that the immigrants and their families consume, whether it's schooling or they should be made to pay Social Security. And that includes even people who do shrubbery, as they do in Princeton. One ought to be required by law to pay a prorated contribution to these people's social services. But we've never actually done that. There are quite a few people who employ undocumented aliens, pay nothing into Social Security, and get away with it. They have them as subcontractors, and God knows. So, yeah, I think you cannot not give health care to these families, particularly the children, because whether you like it or not, these children will one day be Americans.
Well, many of them, in fact, are by virtue of the fact of
That they were born here.
They were born here. But I'm not seeing from congressional leadership or from the White House any serious attempt at dealing with this issue, and I just think I take the points, I stipulate the points you made, Dr. Reinhardt, are accurate, but it is just going to be very, very difficult for us to deal with this issue when we've got that larger looming problem in Texas, New Mexico, Arizona, and California, where it is just going to be very, very difficult to overcome.
But there is the moral hazard problem. If you make health care, this great American health care, available to people, people will flock here ever more.
And that was the argument.
That is the moral. That is why the Congress sometimes says, let's not do this, because we're creating a magnet. But
well, we did that in SCHIP. We essentially said that we were going to remove some of the barriers, and we've turned off the jobs magnet to some degree, but we have to be careful not to turn on the benefits magnet.
In the end, there is a doctor and a nurse and a hospital looking at this human being, and they cannot say no.
Dr. Reinhardt, I will just stipulate that that is correct, and practically every night of my practice life, I was called to do such a delivery because EMTALA said I would have a $50,000 fine and some serious questions to answer if I did not respond within 30 minutes, and yet at the same time, that same federal government failed to protect, secure the borders, and as a consequence, we in the hospitals are left on the front lines of that. I didn't mean to get so far down to that. I did want to ask a couple of questions about the Federally Qualified Health Center issue that Gene brought up. Mr. Green brought up, because it is, the distributional issues are significant. While he has 4, or what did he say? How many did he have in Houston? It's way too many, whatever he said. We only have 4 in Dallas County, 1 in Tarrant County, none in Denton County, where I represent significant numbers of people. The infant mortality rate in Tarrant County in some of the zip codes is phenomenally high, and we only have 1 federally qualified health center, not in the neighborhoods where those zip codes exist. So there it's not a question of access. We've got a good county hospital in Tarrant County. The question is utilization, and we have not put the clinics where the people are so that they will use them, and that is one of the great inequities. I've often wondered why we reimburse at a higher rate for Medicaid reimbursement at Federally Qualified Health Center, and we won't do the same thing for a physician in practice in the community to keep that physician involved and in practice. So, Dr. Reinhardt, you almost went there with the money should follow the individual. Can you expound upon that just a little bit?
Yeah, I think in general, certainly in my profession, economics, we believe in competition, and therefore, whether it's scholarships, it should never be given to a medical school or a university. It should travel with the client. And that is why, ideally, people should have the same insurance. A doctor should get paid the same, no matter where they work. You're reimbursing a professional service, and it shouldn't really depend on what location you do that in. So I sympathize very much with your thought.
And what is a mechanism that money could follow the individual?
Mr. Burgess,
Universal
you're over. This will be the last question.
Universal insurance is, in fact, the mechanism. That's why some of us are so much for it, that if people have purchasing power, like a Canadian has a credit card, and with a credit card, every doctor gets paid the same, whether it's a poor child or a rich child. Well, in New Jersey, we pay Medicaid $30 for a pediatric visit, and for the commercial, $120. Canadians don't do this. This is why I think the Canadian story here is not really relevant to us at this time. They have a different social ethic. They look at life differently than we do. If you did a survey now in Canada, Canadians are not stupid. They're highly educated. They watch American TV. They have a democracy. And yet, if you had a referendum whether they would want our system or keep theirs, overwhelmingly, I would bet a lot of AIG stock on that. Overwhelmingly, you would find, well, it's still worth something.
Yeah.
We'll see to that, actually. We'll stipulate that.
I put real money on it, real New Jersey money. The Canadians would vote for their system. There are, of course, some who are not happy, and they can come here and do research. But by and large, when I go up there, I'm a Canadian too. When I go up there, by and large, people are very proud of this system, and I invite you to do it. Go to the airport, talk to anyone.
Yeah, my father was a refugee from Canada. So
All right,
I
we've got
understand.
to move on here. Next is Ms. DeGette.
Thank you, Mr. Chairman. Dr. Fader, I was wondering if you wanted to respond very briefly to this issue of the undocumented immigrants coming in and and taking advantage of our system.
Thank you, Ms. DeGette. You saw me chomping at the bit.
I did.
I'll be brief. I just wanted to make very clear that although immigration is a very serious problem that does create serious problems for health providers, particularly in some areas, that the problem that we're talking about is we should not ever think that the bulk of people without health insurance coverage or the bulk of people who are facing affordability problems are immigrants, whether they're here legally or not legally. And I also believe that when we're talking about, we asked about universal coverage, we're talking about universal coverage, we are talking about universal coverage for people who are Americans and are here legally. And I just didn't want that issue to get confused.
If you were structuring the universal health care program, you wouldn't necessarily structure it so that we were inviting people to come in.
I think that's absolutely true. And we have seen that people, as Dr. Reinhardt said, people are coming here as long as employers want to hire them and we don't enforce our rules.
Right.
And with the decline in the economy, they're not coming in those numbers anymore. So
Right.
I think that we should, although it's a very serious problem that I wouldn't minimize and faces some institutions in particular ways, it would be a mistake to hold the whole healthcare system and all Americans hostage to that problem.
Thank you. What I really want to talk to this panel about is this issue of a public plan alternative, because I think that, frankly, as we move forward with drafting legislation in this committee, that's going to be one of the top issues of discussion and debate. And some people say, well, we shouldn't have a public alternative, I guess because it leads us down a slippery slope towards socialized medicine or single payer or so on, but we actually do have one of our largest public health care systems right now has a public option and a private option, that's Medicare. And the Medicare fee-for-service option is the most popular option, and people like that. But more importantly, I think, if we didn't retain the fee-for-service option when we did Medicare Advantage, we would have never realized that we weren't getting more efficiencies in the private option that we had adopted. And frankly, I was here when we did Medicare Advantage, and I thought that when we did the private alternative, that it would save us money and it would cause us to revamp our fee-for-service program to get more efficiencies in that program. We all know now that, of course, that has not been the case, and that we're spending far more in the private alternative than we would have in the public. And so I guess maybe, Dr. Fader, I'll start with you. I'd like your comments on why you think it's important to have a public option if we're going to maintain the private competition that we have.
Yeah, I think you nailed it, Congresswoman DeGette, when you said that essentially the public system can keep the private system honest. But we have evidence that private insurers are not negotiating effectively in terms of getting affordable health care. And if we have a public health insurance option remember, because I think it gets misrepresented as a choice, then the public can hold that plan accountable for bargaining effectively with providers, for delivering quality care, for being transparent, for all the things that we need insurance to be. And essentially, it puts some pressure and makes a market that claims to be competitive but is not. It can make it work.
And just to follow up on something, Ms. Pipes, I never try to misconstrue what people who I disagree with say, but what I had heard Ms. Pipes saying is part of the way in Medicare and part of the way it would happen in this system that you would get the efficiencies is by ratcheting down reimbursement for medical services, and doctors wouldn't want to provide those services. What would your response be to that, Dr.?
Well, I find these claims fascinating at a time when the Congress is responding to concerns about physicians in the Medicare program and responding to access problems by raising physician fees. And in Medicare, we make an extra effort to make certain that we're paying appropriately, but that when access problems arise, that we essentially enact higher rates. And we are talking about then a responsiveness to people need access to care, and your constituents hold you responsible for that. So I don't think that this concern that somehow it's going to go to nothing or Medicaid for all is, I don't know where this is coming from.
Dr. Reinhardt?
Yeah, I agree. I served on the Physician Payment Review Commission, your commission, and we every year did a survey of the elderly and asked, do you have access to health care? And that's still part of what MedPAC does, and monitored it very, very closely. And we had rules of thumb. When we saw access becoming even a small problem, we would recommend to the Congress to raise rates. So that in the Medicare program has, I think, been pretty well modulated. But there is another thing that really I find puzzling, particularly around the business roundtable. On the one hand, they complain that we're spending too much on health care. And then on the other hand, though, they're saying the public sector isn't spending enough on health care. And then they also come out that government should stay small. And I sometimes, in my simple mind, try to put that all together. They say they want small government, but they want them to pay more for Medicare so that their rates are somehow viewed the correct rates. Who is to say that private insurers aren't overpaying, particularly since they have so little bargaining power? In some places, take California, even a large company like WellPoint cannot face down a hospital system. And who's to say the private sector isn't overpaying? I mean, you could make that case.
Thank you, Mr. Chairman.
Thank you. Gentleman from Illinois, Mr. Shimkus.
Mr. Chairman, I'll defer to whoever's next on this side, if I may, since I just want to listen.
Thank you. Mr. Gingrey?
Mr. Chairman, thank you. Ms. DeJette was just referencing in Medicare that we have a public...
With the gentleman, it's DeGette, and everybody's, including the president, has been saying it wrong, so I just like...
Ms. DeGette.
Thank you very much.
And it's Diana and not Deanna, is that correct?
You got it.
Thank you. I will remember that. But Ms. DeGette was talking about the public and private plan that we have within the Medicare system, and that the private plan is turned out to be so much more costly. And the reason I bring that up, because Dr. Reinhardt, in your presentation, you talked about the importance of rigorous cost-effectiveness analysis. And I have concern that our way of scoring things in a static environment rather than a dynamic way of doing it. Medicare Advantage, and the President, of course, is certainly taken a swipe at Medicare Advantage and is going to cut that significantly, and to the chagrin, I think, of 10 million people who get their care through Medicare Advantage. If it's true that end-of-life cost is the biggest cost of Medicare, the last month of life, then I think we might be judging that cost of Medicare Advantage prematurely. Now, I'm not saying that it should be 115% compared to Medicare fee-for-service. Maybe it is a little too high. But in the final analysis, it seems to me that if we looked at this in a dynamic way, follow it all the way to the end of life, then it may turn out that Medicare Advantage, the private versus the public, would be much more cost-effective. And I worry in regard to what you were saying, Dr. Reinhardt, in rigorous cost-effectiveness analysis, in regard to medications, in regard to biologicals, in regard to durable medical equipment or devices, that maybe, in fact, these would, by some a rigorous cost-effectiveness analysis, almost like a Federal Reserve Board for health care, that these decisions would be made too early and if we had an opportunity to wait and see in combination with other things, whether it was a cancer drug or a new surgical procedure, that in fact in the long run it would be cost effective. So I'd like for you to respond to that for us.
Well, I mean, first of all, your point of ideally we would like to have a dynamic view is correct. I agree with this. Ideally, what you would really like to have a natural experiment where some people went into Medicare Advantage, some stayed with the traditional program, and you could follow them till they die and say, what were the life cycle costs, adjusting for illness and so on. That would be ideal, obviously, and maybe you're right. It could be cheaper if they manage somehow the last month of life more efficiently. I'm not sure that there's any evidence.
Well, I would say this is very likely that those were managed efficiently over a number of years in regard to wellness and taking care of themselves and taking care of their medications. When it comes to be their final day on earth, it might be a catastrophic event like a heart attack or a stroke, but not in an intensive care unit for months suffering from multiple horrendoplasties, as we used to say in medical parlance.
No, it's possible. I mean, and it's researchable. One could research it even now. You could give the ARC some money, and I speak here with a conflict of interest because I'm a health services researcher, but we could research them.
Yeah, I think you could. And let me ask you one last question, Dr. Reinhardt, before my time runs out completely. You had an article published March 13th of this year in the New York Times. You pointed to two groups who comprise the, quote, opposition to cost-effectiveness analysis, unquote. And you said one of those groups were manufacturers of pharmaceuticals and biotechnology products or of medical devices. But the second group, and this is what I want to address my question to, you said the second group are individuals who sincerely believe that health and life are priceless. And you went on and you said in describing this second group, you state that for them, cost should never be allowed to enter clinical decisions. It is an utterly romantic notion, and if I may say so, also an utterly silly one. No society could ever act consistently on such a credo. That's the end of your quote. Dr. Reinhardt, do you believe that we as individuals in America should have the ability to value our own lives, or is this something we should ask the government to do for us, i.e. ration that care when you get to be 90 years old and you need a hip replacement? Do you just let them fall and break the hip and die of pneumonia, or do they get the opportunity, if they value that, to get that hip replaced?
I cannot even tell you, Congressman Gingrey, how much I hoped someone would ask me this question. Because this is how I would think about it. Every American should have the right to value their own life any way they wish. But then the question is at whose expense? If it is at their own expense, by all means. But if you are dealing with a collective insurance fund, then those who preside over those funds do have at some point to ask themselves, at what price do I buy additional life years, quality adjusted, we call them QALYs, or additional health? And to say, we don't make airports as safe as they could be. Our air traffic control system is reckless, I think, from what you read, in what often near misses. And why don't we do it? For over money. We may calculate. Our son fought in an unarmored Humvee. That was a calculated decision to say, well, it would cost so much to have armored vehicles, we're going to take a chance on the life of some Marines. And that's what the Congress does. So what I listed there is a paper that shows the value on human life legislators and people routinely put on their own life, and they are rather low numbers in many ways. And I raise the question, why should healthcare be the only area in an economy, in society, where I have the right to say, spend the limit, spend $5 million on me, and let the taxpayer pick up the tab? I think that notion, to my mind, is romantic and, in fact, silly.
We're
like a German philosopher just a year.
Mr. Gingrey, I'm sorry, but we just have a lot of people, and we got another panel. Next is Ms. Capps.
Thank you, Mr. Chairman. And I want to use my time really well with great panel. And I have a question for each of you, starting with Ms. Pipes. In your testimony, you talked a lot about rationing care and waiting lists. And Canada does have bad wait times, but so does the United States. 23% of adults reported having to wait over 6 days to get an appointment to see a doctor the last time they needed one. In the UK, which also has a single-payer system, it was only 15%. In addition, 34% of sick adults in America who had medical problems skipped important doctor visits because of cost. That's way more than the 4% in the UK and the 7% in Canada. Not to belabor that, because we're talking about American system that we want to try to reform. Is there any data you can present to this committee showing that a new optional public health plan will create rationing times or wait times worse than what we're seeing right now?
Well, I haven't done the exact research on that particular issue, but I think
so there is no
on,
documentation that you know of?
Not that I know, but I can look into it and find that out.
That would be great. If you can find it, I'd love to have it for our...
Because I think, you know, Canada does have long waits, and people that have money come to the United States and pay out of pocket.
You said that in your testimony.
So it's very important that we improve the U.S. system so that people can get better access. And that's why I support universal choice, because a young man of 30, you know, wants to get a high deductible insurance plan. Why should he have to pay $12,000 to $15,000 to cover my in vitro fertilization? You know, I mean...
Thank you very much. And if you can find that information for us, I think it would help us to make some good decisions. Dr. Fader, I mentioned a story in my opening minute about a constituent of mine who lost her job and had a reoccurrence of her cancer. She did well in the county that I represent because they have a particular public access program that worked for her. But I want you to be able to elaborate briefly, but for our value, what you were saying about how when someone loses employer coverage, their ability to purchase coverage in the non-group market is limited at best.
Yeah, well, it is, you're absolutely right. In your community, she had an option. She had what is called a pre-existing condition. She was sick. And you're going to hear on the next panel from my Georgetown colleague, Karen Politz, who can give you examples, a tremendous number of examples of this kind, that people in the non-group market essentially does not either denies people who have conditions, rules out coverage for the body parts that have been damaged, limits the benefits, or charges higher rates. The market simply does not work for people. It's not any kind of safety net, and the evidence on the non-group market is that rather than people falling into that system and getting picked up, it ends up people are healthier in that market than in the employer-sponsored system. So this woman, without your plan, when she most needed care, would have lost any means to get access to it. And we know, looking at the evidence in general on the uninsured, that people are actually dying in that circumstance.
Thank you very much. And
people do. I mean, I think if we change, because people get their insurance through their employer and it's not portable if they lose their job. This is one of the reasons why changing the tax code so that people can go into the individual market. And also, I think we'll see more competition and new insurance companies that will deal with specific people.
We'll see about that.
They don't compete. They don't compete for sick people.
That's right. If there's anybody who can show a plan where they compete for sick people, we would love to hear about that too. There's another topic that's very dear to my heart, Dr. Reinhardt, I saved for you. In the United States, we spend nearly $7,500 per person on health care. It's the most expensive system in the world, if I'm not mistaken. Yet, in terms of maternal mortality, women dying in childbirth, we rank 41st out of 171 countries. So there's a disparity there. How can we now, as we want to design, reform our system, what are some proposals specifically that would improve issues like maternal health, a classic indicator, according to the Millennium Challenge, for the overall health of a nation, while striving for lower costs?
Well, obviously, part of the reason why women die has to do with issues outside of the health system, and every health services researcher would recognize this. But when you come to infant mortality or maternal death, the health system does have a contribution to make, and I think we're falling short. It's because people often do not have insurance, particularly when you're just slightly over the Medicaid limit or live in a state with a low threshold. And I must say, as a European and ex-Canadian, I'm stunned at this. I believe the children are the treasure of a nation. They're the future generation. And I always have said, to me, mothers are on par with soldiers. They do a patriotic service because they bring us the next generation. We should give them medals rather than the way we treat them. And I remember I once gave a speech called Motherhood and Apple Pie, where I said, I do buy the idea that Americans love apple pie, but I'm not so sure about motherhood. I don't think in this country we respect mothers enough, and I have people who know me know that's a big deal with me. We do not respect mothers enough.
It'd be worthwhile you looking at some of the work that June O'Neill has done on infant mortality rates, because other countries, we have the best neonatal procedures and clinics and facilities in this country. And often in other countries, people are not counted as live births. And so look at the work that June O'Neill has done, because you have to compare apples with apples.
I was talking about maternal mortality, but
Right.
our infant mortality rate's not so hot either.
Well, but I think you have to compare on an equal playing field how other countries treat what they just count as infant mortality rate versus this country, because we keep a lot of babies alive that wouldn't even be counted as live births in other countries. So it's very important. Look at June O'Neill's work on this issue.
Thank you. Next is the gentleman from Arizona, Mr. Shadding.
Thank you, Mr. Chairman. Ms. Pipes, I'd like to begin with you. I think I've heard you describe what you favor as universal choice. Are you familiar with plans that have been introduced that would provide every American with a stipend that is either a tax credit or a refundable advanceable tax credit that is cash to go buy a health care plan for every single person? Are you familiar with those, and would you describe that as universal choice?
Yes, I would. And Mr. McCain during the campaign was sort of hit by Mr. Obama saying, Mr. Obama said Mr. McCain would like to tax your health care. Well, in fact, the plan would be...
Well, I don't want to talk about his plan. I want to talk about some quick questions, and I've got a long list.
So, but I think it's a
Would
good
you say that we have a patient choice-driven system now?
No, I would not. I would say 47% of health care is in the hands of government today, and we have a small sector. 7 million people have patient-centered health care.
Would you include in that patient-centered health care plans that are picked by your doctor? Don't we really have a third-party control system in America today where your health insurance plan is picked by your employer and the plan then picks your doctor and you have virtually no choice?
Absolutely. And that's why if we can move away from employer-based care and move up the individual market, people will be, new competition will come in, new insurance plans will be available, and people will be able to choose the type of plan that fits their individual.
What if we let them choose from the private market or choose their employer's plan, but put the choice with them?
That's an excellent idea, yes.
Would you say that we would have a healthy market in health insurance in America today?
No, I would not.
This represents the Northern Virginia residential phone book. All of the people in that book get to buy auto insurance if they have an auto, right?
Right.
If I put up here the Northern Virginia business phone book, it would be a fraction of this size, would it not?
Yes.
Maybe a fifth or less. That would represent kind of a graphic of the health insurance market versus the auto insurance market today. That is, only employers get to buy health insurance, and they make the decision for their employees, whereas in auto insurance, everybody gets to make their own choice and gets to pick a plan, and we have a much healthier market. Wouldn't you agree?
Absolutely. And, you know, if the average employer spends $12,000 per year on an employee's health plan, maybe even $15,000, but the thing is that not all employees need that much health care, and there would be more competition if people could choose, like in the auto insurance, the type of insurance that fits their needs, and some will be a lot cheaper.
So you would favor a system where they get to make their own choices?
Absolutely.
And moving away from a system where there's a third-party control?
Right.
I take it then you would not agree for moving from a system that is third-party control by your employer to third-party control by the government. Is that going to solve the problem in your view?
I think that if the government takes over the healthcare system and including this public plan within the National Insurance Exchange, it's going to reduce people's choices, costs are going to go up, and ultimately care will have to be rationed, as it is in countries like Canada and the UK.
Dr. Fetter said, and I agree with her, that affordability is the real key here. We're worried about expense. We're worried about how expensive health care has become,
right,
and how expensive health insurance has become. Do you think it's a coincidence that we are experiencing a huge spiraling cost in healthcare costs where it's all third-party control and the market doesn't include all these people, it just includes this little business phone book, that we are only experiencing that spiral in cost in the one place in America where there is genuinely no market? Is that a coincidence?
Well, as you have said, I mean, we don't have a free market in healthcare. We have a lot of government in healthcare. We have the third-party payer system, and people are not in charge of their healthcare. We don't get our life insurance, our long-term care insurance through our employer.
We've pretty well divorced the consumer of healthcare services from the payer
of
healthcare services.
Absolutely.
And once divorcing them, the costs have gone up dramatically once we've divorced the consumer from the payer.
Because we have in this country what you call first dollar coverage. When people think they pay nothing, if employees don't pay anything for their premium, or they pay a little bit, or they pay no copay or a small copay, first dollar coverage means when people think something is cheap or free, they demand a lot more of it.
And they think it's cheap right now because their employer's paying for it.
Yes, and then
let me switch topics. A lot of discussion here today about a public plan. If we institute a public plan, won't politicians have a tendency to increase the subsidy of that public plan year after year after year as they've done with other public offerings?
Well, I think if you look at Canada, when the government took over the healthcare system in 1974, they were completely taken aback by how much demand there was for a program that people think of as virtually free because they don't know how much they're paying through the tax system. And it went up and up, and then government has to put a cap and say we can't spend.
I'm almost out of time, but if we let the government create a public plan and increase its subsidy year after year, I really have two questions. One, how will the private sector stay in competition with that if the government sector's subsidy goes up year after year? And second, if the government both offers a plan and also sets the rules for its plan and the private plan, aren't we allowing the government to be both a player in the game and a referee in the same game?
Right, and that was what I mentioned in my testimony. If you have guaranteed issue, community rating, and a lot of mandates, that is going to push up the cost of the plans. And if the government prices their plans slightly cheaper, you're going to crowd out the private insurers and leave us with a taxpayer-funded plan, which ultimately will be too expensive and end up with ration care. And it's not going to help the American people get the finest health care available.
You'd rather give them cash and let them make a choice.
Right, absolutely.
All right. Thank you. Gentlewoman from Illinois, Ms. Schakowsky.
Thank you. If I could just ask each of you, do you think that health care is a right?
Yes.
Ms. Feder?
No.
Healthcare is too big a label. Some kind of healthcare is absolutely a right, viewed in this country. It's not in the Constitution. However, think of someone lying in the street, a car hit them, they're bleeding. Does anyone in this room think you don't have a right to be picked up and brought to the nearest hospital? Does any American think that right does not exist? So, yes, some healthcare, a lot of it is a right, and some of it, like plastic surgery, is not.
Well, that's not necessarily health care.
Cosmetic surgery.
Yeah.
And we do have, as someone mentioned earlier, EMTALA, I think it was Ubi, that we have EMTALA, which is a law that says no one can be denied access to an emergency room.
I know, I'm just asking if you think it's a right.
No,
you said you don't.
How do you determine how open-ended that right is and what it will cost? And so I think that we're entitled to life, liberty, and the pursuit of happiness.
Yeah,
we need access.
It's my time, and I reclaim it. What would you say, Ms. Pipes, though, that 87% of Canadians view the elimination of public health care as a negative? This is according to McGill professor Stuart Soroka, author of the study. It was the highest ranking opinion in the entire survey, that they would not want to eliminate their public health care system.
Well, there's poll numbers that have come out of Decima that the majority of Canadians, 47% versus 41%, are dissatisfied with the Canadian healthcare system.
Well, you spend about 10% of GDP, you said, on health care in Canada. What do we spend, Ms. Feder?
16% here.
Okay.
More than that.
But it's going up. It is going up, yes.
Yeah. So, in other words, perhaps if more were spent on the Canadian healthcare system, it could serve more people. But I'm not looking for a comment now. I'm concerned about this notion, and you referred to it earlier, Dr. Reinhardt, and I'd appreciate if you or Dr. Feder would want to comment on that. The United States, it seems to me, does in fact ration health care. That the dollar bill is essentially that ration card, and that when you have more than half of Americans who say that they haven't gotten health care, they have postponed or have completely eliminated health care that they need, that clearly this health care is being rationed, that people, we don't count the people not in line because they can't afford it. And I wonder, I think this is really an important point about comparing our system with a Canadian system where they actually count people that wait in line, and either one of you or both.
Yeah, I appreciate the question, Congresswoman Schakowsky, and the first point I would make is, as you were making earlier, is that we are not talking about turning the American system into the Canadian system. We're talking about slowing the growth and making sure of healthcare costs and making sure everybody has affordable insurance and affordable care. And as Dr. Reinhardt said earlier, that when people can't afford care, when they don't have insurance coverage or there are holes in their insurance coverage, care is being rationed. And I find very interesting, not just people who aren't showing up because they know they can't afford it, but how much do you hear from your constituents about the runaround they get from their insurance companies, the denials, the submitting the claims over and over again, the not being able to get service?
All the time.
Exactly. So what is it? We think the system works. It's being compared to a straw man. What we need to do is to fix our system, get better value for the dollar, and make sure that everybody gets access to care when they need it.
And prescriptions left in the drawer because they can't afford to fill them.
We have the evidence of it.
It so happens I've written 3 papers on this rationing issue. One, in fact, entitled Styles of Rationing, Canada versus the U.S. And there is no question they do ration with a queue for some procedures up there. And there is no question we ration through price and ability to pay. And to deny that defies anything any freshman is ever taught if they have a good economics professor. I could show you textbook after textbook from people who are actually conservative politically, who says the role of prices is to ration. And we use price as a rationing device. We also know it. There was a recent study out, Judy, you may know it, that showed for low-income people, they actually consume less health care because they very often are uninsured. But if we compare people who do not have insurance with those who have insurance, Jack Hadley's numbers, the uninsured get 43% of the care that similarly situated insured get. And to deny that that is rationing borders on the mischievous. I think that is rationing, and we are discussing styles of rationing. Canadians have a different view about what is equitable than what apparently we have.
Thank you. Bottom line, we want to do an American system that works for everyone. Thank you.
Thank you. Gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. And I did, by listening, appreciate a lot of the comments, and I don't think it'll be long. Following up on John Shattuck's comments about buying power, just 2 quick questions. There is a debate for those who propose that about it being a mandatory or voluntary system. If you use the automobile insurance debate, if you drive in states, you have to have insurance. Right. I'm of the point of view that if you went to a private option of what's called the public choice, however we're going to define that, that it would be, everyone would have to cover, I mean, you would not have a choice to be out. Everyone would have to have something. You would also have to force then the insurers to have the wide breadth of everyone involved. I mean, you have to hold, you couldn't allow them to cherry pick is kind of the terminology I use. And it's a mandatory system. And the final thing is there would have to be, the basic package would have to be a catastrophic package. I mean, the cost shifting, what goes in a hospital, and what everybody's worried about is catastrophic care. And maybe you could allow people through health savings accounts or just their own dollars to do the preventative care, to go to the doctor for the for the cold and flu and all that other stuff. What do you think about that premise? And if you, Dr. Reinhardt, if you would just then mention it, and Ms. Pipes and Dr. Fetter, and that would be the only question. This is what's been bubbling around in my thought process. How do you get to the 44 million or 47 uninsured Americans? They have to have insurance. They have to have a catastrophic package. That's what what would you say to those comments?
Well, ultimately, when you discuss universal coverage and when do you know, how have you reached this fairly? The only metric that really makes sense to me would be to say what fraction of a family's discretionary income after food, housing, and shelter should a family in America be required to contribute towards its own health care. And presumably that percentage would be small for a waitress or a cab driver, and it would be higher for a full professor at Princeton. You could easily ask me to contribute 10, 12% of our household budget towards health care, and you would not ask a waitress to do that. So that's the first thing. Now, with respect to the choice market for private insurance, if you put community rating on, say you must charge everyone the same, sick or healthy, and guaranteed issue, if you don't couple that with mandatory insurance, you will get the death spiral of private insurance, which we actually see in New Jersey happening. So those two go together. The alternative model would be that you say, okay, we let the private insurers medically underwrite. So if somebody is sick, they pay a huge premium. Somebody has AIDS, they pay $80,000 a year, and someone who's very healthy gets it very cheap. But then you would have to have a bureaucracy that could give subsidies to the chronically ill with the huge premiums that they're charged and subsidize them to the tune that ultimately you're happy with that percentage. And this is really something, I think my colleague Mark Pauly at UPenn, and who's the co-author, had a very lovely paper on this. How do you know that you're equitable? And he says he proposes this metric. Adam Wagstaff at the World Bank had the same thing for the international scene.
Yes, sir. And I don't want to cut you off. I do want Ms. Pipes and Dr. Fetter briefly. I only have a minute left. If you could kind of summarize that quickly. Sorry, Dr. Reinhardt.
No, and you mentioned mandatory car insurance, but 15% of drivers in this country, even though all states but 2 have mandatory car insurance, are driving around without car insurance. And we've seen the experiment in Massachusetts, where now, after it'll be 3 years old in April, that still 2.5% of people are uninsured, and about 60% of the people who are people signed up for the Commonwealth Care, the subsidized thing. So it's very hard to take the American mindset and ensure and make them do. I mean, Hillary Clinton said the only way you could enforce a mandate was to garnish wages. I don't think that's the American way. And so I think it's very hard. But if we have, universal choice and people can choose the system that best suits them, I think we will get a lot of those 45.7 million Americans going into the insurance market. There's nothing wrong with having a high-risk pool for people who are falling between the cracks.
Thank you, Dr. Fetter. With the chairman's permission.
Yeah, it's okay?
Yes, sure.
I'll be quick. I was interested in what you said about making rules for insurance, because as I listened to Mr. Shattuck, no matter how big that phone book gets of insurance companies, if 20% of the people account for 80% of the spending we spend on health care when we get sick, insurers always win if they insure us when we're healthy and avoid us when we're sick. So you've got to have rules. It's got to be group insurance. That's the only way it can work. I am less concerned about mandates than I am concerned about making sure that everybody has the wherewithal to buy insurance. So that means subsidies, making those adequate. And also, I think facilitating enrollment in many ways can get everybody into the system so that we fix it. Not only, people don't walk around with a U for uninsured on their foreheads. There's a problem in the whole system, and we need to make it work for everybody.
Thank you, Mr. Chairman.
Thank you. Mr. Gonzalez.
Thank you very much, Mr. Chairman. First, just a couple of observations. Trying to use the car insurance as an analogy is a terrible mistake, because if it operated like health care providers, what would happen is your first accident or speeding ticket, the insurer would drop you. Then you go to the next insurance company, and they'd say you had a pre-existing condition and wouldn't offer you any insurance. The other observation is anybody that doesn't believe that our health care system is broken would be those individuals that presently have coverage, number one, but even out of those, you'd have to say it'd be those that are healthy and haven't attempted to use the coverage.
Right.
I'm going to quote from a paper from 2004. I get these all the time from a physician friend of mine. Every time we have a hearing, he'll send me an email and refer me to articles. But I'm going to agree with this article, and I think it's going to embrace some of the concepts that have been advocated by members on the other side of the aisle here in the committee. And this is by Michael Porter and Elizabeth Olmsted Teesburg. We believe that competition is the root of the problem with U.S. healthcare performance. But this does not mean we advocate a state-controlled system or a single-payer system. Of course, what we have here is we're talking about a public option, which is separate, because those approaches would make things only worse. On the contrary, competition is also the solution. But the nature of the competition in healthcare must change. Our research shows that competition in the healthcare system occurs at the wrong level, over the wrong things, in the wrong geographic markets, and at the wrong time. Competition has actually been all but eliminated just where and when it is most important. The healthcare system can achieve stunning gains in quality and efficiency, and employers, the major purchasers of healthcare services, could lead the transformation. This paper was written in 2004. The jury was out, juries come in, employers have not been able to do it. Someone has suggested that a well-educated consumer will be able to do it as long as we give vouchers or some sort. And that we know that we don't have that level of competency out there, through no fault of the consumer, of course. I would like comments from Dr. Reinhardt and Dr. Fetter as to the way I view this, without trying to be married to any kind of ideology to the point of a faith or a religion that doesn't allow us to discuss this thing rationally and in good faith. I believe what we're espousing here, and hopefully we'll have a bill, which is going to be a public option, will be the vehicle that will allow us to bring into the marketplace those wonderful ideas of competition, consumer choice, education, quality, efficiency, and get us our biggest benefit out of every dollar. Is this what we see here today? That's what I really think we're discussing, because we're really talking about concept at this point, and we may bring into immigration and other things, but those are issues, and we'll have, for another day, we'll have those particular issues. But overall, conceptually speaking, is that what this will bring to this debate as far as a public option? Dr. Reinhardt.
Well, this paper was in a Harvard Business Review by them, and then followed by a huge tome that they wrote, and a number of us reviewed it in Health Affairs. My view is their vision is correct but very utopian, because somehow they pretend that you can slice all ill health into episodes that begin and end, and that you can get physicians and hospitals and convalescent centers to build little groups that specialize, little focus factories, as Reggie Hertzlinger calls them, that specialize in this, and then advertise their price for the whole bundle and have a quality rating. And they don't even say who would do that, who would rate the quality. So as a concept, it's good, and I think we're gingerly moving that way, but it'll take at least 20 years before you would have realized that. But it is true, a public health plan does have the advantage of being able to experiment with that just like a private plan. I would urge you to think, they always say Medicare wasn't an innovator. Who developed the DRGs? It was Medicare, copied now around the world. Who developed the resource-based relative value scale for physicians? It was Medicare, now copied by every private insurance plan. So I believe the vision they had is good, and competition is a good thing, and none of us are against competition. But in the meantime, we have American families in dire need. We cannot wait for utopia, and we have to make sure. One of the principles, the President said, American families should not go broke over health care. I think on either side of the
Dr.
aisle.
Reinhardt, I do want to give Dr. Fetter an opportunity. I only have a minute left. I apologize.
I would, I'm for affordability, to finish Dr. Reinhardt's sentence, but I would say that what we're talking about in terms of paying more effectively for medical care is what we're talking about. So whether it's episode-based or better rewards for primary care or refining what we do in the existing system where we're overpaying within some DRGs, we've got a lot of room for improvements. And what you've put forward is that a public health insurance option can be a leader not only in payment reform, but also in managing chronic illness, in promoting prevention, and all. We focused so heavily on fees because that is, I think, another straw man. What we need to focus on is leadership and accountability to us as an option in the health insurance system.
Thank you. The gentlewoman from Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman, and I want to also thank the panelists this morning for, I think the discussion will hopefully guide us through the minefield that we face trying to get to universal coverage and hopefully help us to shape a bill that we can get passed here and in the Senate and signed by the President. My first question is to Dr. Reinhardt and to Dr. Fader. I have a little bit of discomfort around the public plan, which both of you support as well as many others, because help me understand, is this the same as Medicaid or different to Medicaid? Are you going to have Medicaid for the poor and a public health, would it be a public health plan for everybody else? Or wouldn't that be continuing the same kind of two-tiered system that we're trying to get away from? And shouldn't it just be one public plan that Medicaid patients would have paid for them and others paying according to their income? Or is that what you envision anyway?
Well, as a practical matter, you would probably have to go with a separate plan because Medicaid involves the states. And that system, to fuse that with a public plan, which I think would be ideal, would be very difficult because the states might object to that. And then there would be an issue of the fiscal transfers to make that possible.
Yeah, I would just say to think of a public health insurance plan not as Medicaid, but think of it as a publicly owned, publicly accountable insurance option that you would be able to choose alongside private insurance options, with everyone having a guaranteed standardized set of benefits. So they would compete on their ability to deliver care efficiently, couldn't discriminate based on health status. And I would distinguish that from the importance of retaining Medicaid. Medicaid is not only do we have statutory law that provides, or statutes that protect very low-income people that we should extend, I think, to all people below poverty, but there are a whole body of law defined through litigation that actually protects very low-income people, and that, I think, to disrupt that would be a mistake.
It's not that I want to disrupt it, it's just that Medicaid has not been really providing the kind of outcomes that we want to see, but
now,
we can fix that as well.
Your concern is well taken, and that gets to whether we're paying providers adequately to serve people. So we want to keep the protections, which is if we have it as a public health insurance plan among choices, it's not going to have as generous benefits as Medicaid has.
And Dr. Reinhardt, one of the people on the other panel, Professor Biker, I guess, spends a considerable part of her written testimony on the problem of the sick and the uninsured, which is a population group that I'm particularly concerned about. We, in the Tri-Caucus, spend a lot of our time and focus on eliminating health disparities in poor racial and ethnic minorities, rural individuals, and they would be sicker and prominently among the uninsured. And because they're sicker, bringing them into the system, Professor Biker would say, would drive up the cost of care. It drives up the cost of care now, affects the quality of care for the uninsured. So how do we ensure that their high costs, because we're bringing them in to make sure that they have access to care, how do we work the system so that it doesn't drive up, so that we keep insurance affordable and still provide that high level of service at the outset? Or should we just make the investment and not worry, know that it's going to pay off in the long run?
Well, I wouldn't say make the investment and not worry about it. I would say make the investment and then worry about a long-term strategy to take costs into our gun sights and really start looking at how much, for example, do we spend on administration that buys no health care that could be reduced. How much these Wenberg variations I talked about in Medicare, and you have them in the private sector as well. So I think cost control, we ought to be able to do this more cheaply than we are in America. Even the Business Roundtable says that. But you can't wait. These American families are hard-pressed. We're facing a deep recession. There'll be ever more of them. And to say, if there's somebody who is poor and sick, and now we serve them, and that'll drive up cost, I would say yes, it will. But that's why you're doing it.
And this is not to eliminate the need for focusing more on prevention or other programs to eliminate the health disparities. I know, well, it's part of the testimony in the other panel, and I wanted to get a response on that. Ms. Pipes, despite your data that shows that the Canadian system may not be working as well as many purported to be, how do you explain the 20 or 23% value gap? Our country is running 20 or 23% behind yours on the value we get for health care. How do you reconcile those two things?
Well, I think that, Canadians, a lot of Canadians come to the United States and get health care when they're on waiting lists. So I think it's very hard when the government runs a health care system to actually measure, what actual comparisons between a totally government-run system and a system that is a hybrid of a number of different types. So I think, I don't know where your number comes from, but I haven't analyzed that number, and I would be interested in it. But I will say that 250 Canadian doctors leave Canada every year to come and practice in the United States, not just for the money because they can make more money, but because they can practice the type of medicine that they're trained to practice. Because doctors in Canada are basically union members. I mean, Dr. Reinhart mentioned that. When you work in a province, whether you work in British Columbia, your medical association negotiates your fee with the provincial government. My cousin's a corneal transplant specialist. He hasn't had an increase in 4 years because the government is in a deficit situation. And so doctors, it doesn't matter whether you're the best cardiac surgeon or the worst, everyone gets paid the same, and it destroys the incentive to attract the best people into healthcare and into medicine. And so, we want to continue to have, America has the best people come from all over the world to get health care here, whether it's Silvio Berlusconi coming from Italy to get a pacemaker. We need to make some changes to build on the system we have and not break it down and have a public health plan that I think will crowd out the private insurers, because when you're adding tremendous costs with guaranteed issue, community rating, and these mandates. So I just think that universal choice will lead us to universal coverage, because young people, of the 17 million Americans earning over $50,000 a year, 2/3 of them are young people, and they don't need every single aspect. They want insurance to be insurance for catastrophes.
Well,
your time's over. Ms. Castor?
Thank you, Mr. Chairman, and thanks to the panel. I'd like to go back to what is driving these huge increases over the past decade in the cost of health care. And recall that health insurance premiums have outpaced wage growth. From 1999 to 2008, premiums grew at 3 times the rate of wages. And Dr. Reinhart, in your testimony, you said that we've seen that just over the past 7 years, the average total outlay on health care for a family from all sources has nearly doubled. And folks back home, they want to know why. It's out of control. One easy answer has been when I go to the hospitals, that's an easy case, because they say, gosh, the uncompensated care, the folks that come into the ER that do not have health insurance and have chronic disease or something, that translates to them. They get that, and they say, they understand we're subsidized. If you have private insurance, they're subsidizing part of that uncompensated care. The hospitals in my area, in turn, have developed a clinic system with very low administrative costs. It's a partnership with the private doctors, private hospitals, and nonprofits, and it's saving everyone money. But what else is driving these astronomical increases, lessons that we can learn moving forward as we develop this public choice option? Doctor?
Well, the American system is expensive because we have structured it to make the demand side weak and the supply side strong. And all the other nations that are cheaper have a strong demand side or a stronger demand side and a weaker supply side. And it's really how you apportion the market power. I mentioned that even in a large insurer like WellPoint had real trouble negotiating with the Sutter Health System in California because it's a big system. You cannot run a health insurance plan without having that in your network, and therefore they had all the market power. So I think it's quite clear. It's part of the reason why we have a very luxurious system, overstocked. You read MedPAC, we have too many MRI machines. Canada may have too few, but everyone agrees we have too many. It's because we essentially turned over a disproportionate amount of power to the supply side of the system.
Let me answer it a slightly different way. I think that your constituents I think your constituents will have had the experience of being bumped from doctor to doctor, having tests duplicated, finding it impossible to get, being stuck in a hospital, not able to get out, seeing attempts at treatment that seem to be not to work. What we have, what we're lacking, and what we're talking about with comparative effectiveness research, is to provide an information-based, real evidence, so that you don't go to what Uwe's talking about, the supply side. You don't go to the pharmaceutical companies to find out which medication you need. You have an actual evidence base that enables you to know, enables doctors and patients to decide together on what works and what doesn't. And we can refine our payment mechanisms so that we are actually able to encourage and reward the provision of services that work and the discouragement of services that don't. There is no mechanism for that now, and that we're talking about developing that not in a punitive way, not in an arbitrary way, in a way that enables physicians and patients to choose.
You know, let me ask you all this. I'm starting to hear much greater concern as folks realize the astronomical salaries in the corporate sector and healthcare, and the HMOs are not immune to this. And I wonder if you see any analogy in what's going on in the financial system to healthcare. This is again a segment where the government, the taxpayers, are subsidizing private HMOs, and CEOs are making a multi-million dollar. We're talking over 25 million, 50 million per year. Is this also a factor in high costs? Shouldn't some of this be plowed back into people's health and not paid out in these astronomical salaries?
Well, if you think of the former United CEO who had $1.6 billion, the bulk of that income actually came from stock options, which is taken away from shareholders and not customers. So one has to be somewhat careful of how that salary is composed. If 50 million were a salary booked into payroll expense and added to the premiums, then of course it would be driving health care costs. But if it comes out of stock options, then it's another story. And he got 1.6 billion simply because during his reign the stock went up and up. What is much more troublesome to me with private insurance is that as an industry, I think they have not done enough to reduce the administrative cost of healthcare, that the amount of money they need to run the business is higher than I think it would be if they were all electronic, had a common nomenclature, common claims form, etc. The president of Johns Hopkins mentioned in a speech not long ago, he deals with 700 distinct managed care contracts, each with different terms and so on. If you were to look at a Canadian, there was just a program. They were looking at a Canadian hospital and American hospitals in terms of the billing clerks. You would be shocked at the difference. That's where the real money is, not so much CEO salaries.
Well, also, I think that Dr. Ben Zeiker of the Pacific Research Institute did a study comparing administrative costs of government programs versus the private sector. And there are a lot of things that aren't included in the government Medicare and Medicaid. So I think you should take a look at that study.
Well, that's interesting because the example of my local community that is a collaboration of the hospitals and doctors and our county government, our administrative costs are way low, and that's been proven out for a number of years.
I urge you to look.
We're going to have to end on this one. Sorry. Mr. Braley from Iowa.
Thank you, Mr. Chairman. Ms. Pipes, you have certainly been a prolific commentator on healthcare issues. Do you hold yourself out at this hearing as a healthcare policy expert?
Yes, I'm an economist by training, grew up in Vancouver, went to college there, and was an economist at the Fraser Institute in Vancouver, and then came to the U.S. in '91.
One of the things that's been difficult for me to do is ascertain the extent of your educational background. Do you have any advanced degrees in economics?
I have an honors degree in economics from the University of British Columbia, and then I joined the Fraser Institute working under Dr. Michael Walker, and started out as an econometrician. I won the Canadian Crystal Ball Award.
So the answer to my question would be no, correct?
No, I have an honors BA in economics, but have worked in the economic research field for.
And you don't have a master's or PhD in healthcare policy?
No, I don't.
Or in public policy as a general concept?
No, but I've worked in the field.
All right. On the website for the Pacific Research Institute, you are identified in your individual bio as a scholar. Are you aware of that?
Yes, I am a scholar. I write a lot on healthcare. I write books.
Have you published any scholarly treatises in a peer-reviewed journal of economics on healthcare policy?
Yes.
And can you give us some examples?
I've done some things in health affairs. Over the past, and in Canada.
But can you just identify the scholarly journal that's a peer-reviewed journal of economics?
Right. Well, Health Affairs is, I think, I don't know whether you would say it is, but
it's peer-reviewed.
Yes.
All right. And do you have a CV or resume that you use for your official purposes?
Well, I use what we have on our website. I don't. I mean, I have one in my desk from when I got my job in 1991. I don't keep it up to date, but I could. I mean,
do you have a listing of your publications, a listing of your appearances? Some people do this as a way to let people that they're speaking before know what the content of their background and expertise is. Do you have such a listing that you could provide to the committee?
You'll see that I write for the Wall Street Journal and the...
Just please answer my question. I don't have much time.
Sorry.
Could you provide that to the committee?
Course. Yes.
Okay.
Or you can...
Now, one of the things you asked about, or you raised in the conclusion of your opening remarks, was the need for medical malpractice reform. Do you remember that?
Yes.
I'm sure you're aware that the Institutes of Medicine has done a series of 3 important studies dealing with the issue of preventable medical errors and the cost that they contribute to the overall healthcare economy of this country. The seminal work was the first work in 2000, To Err is Human, and in that report, the Institutes of Medicine concluded that preventable adverse events are a leading cause of death in the United States. The results of the studies imply that at least 44,000 and perhaps as many as 98,000 Americans die in hospitals each year as a result of medical errors. Deaths due to preventable adverse events exceeds the death attributable to motor vehicle accidents, breast cancer, or AIDS. That was then followed by another seminal study, Patient Safety, also from the IOM. And in that study, they included the finding that the committee strongly believes that patient safety is indistinguishable from the delivery of quality care. A new delivery system must be built to achieve substantial improvement in patient safety, a system that is capable of preventing errors from occurring in the first place, while at the same time incorporating lessons learned from any errors that do occur. And then we had the important 2006 study from the Institutes of Medicine, Preventing Medication Errors, which concluded that medication errors are surprisingly common and costly to the nation. The committee concludes there are at least 1.5 million preventable adverse drug events that occur in the United States each year. The true number may be much higher, and they issued a conservative estimate that these adverse drug events cost our economy at minimum $3.5 billion a year. So what I'm wondering is why, when we talk about reforming our healthcare system, don't people who come from your point of view come to this committee and talk about constructive ways we're going to reduce preventable medical errors, which we all know are the most dramatic way that we can reduce the cost of medical malpractice in this country.
Well, I think you should look at some of the work done by Dr. Betsy McCoy, who has done work on infectious diseases and shows that more people die in hospitals from infectious diseases by a major part compared to medical errors. So I think that's important.
Let's talk about that, though, because are you familiar with the Joint Commission on Accreditation of Healthcare Associations? And are you familiar with their Sentinel Event Program?
Right.
Do you know that in the first 10 years the Sentinel Event Program was in place over a 10-year period? Only 3,000 Sentinel event reports were filed with JCAHO, which is astonishing considering the incidence of preventable medical errors that resulted in deaths only, not serious injuries, when those numbers would suggest that they should have been receiving 44 to 98,000 reports at a minimum. So isn't it clear that the system of accountability that we currently use is completely failing American health consumers and making a more safe system?
Well, I think all doctors are interested in people living longer and healthier lives. And as I say, more people are dying from infectious diseases in hospitals than from medical errors. Unfortunately.
Well, I would disagree with that characterization because most people would tell you who study this issue that one of the most preventable forms of an adverse event in a hospital setting is nosocomial infection. And in fact, there's been a lot of research that indicates that despite overwhelming evidence from medical economists, hospitals are reluctant to move to a business model that will allow them to reduce the incidence of nosocomial infections. So I disagree with your characterization that a nosocomial infection is not a preventable medical error.
No,
I'm going to let you, Ms.
right.
Pipes, I'm sorry. I'd like you to respond, and then we have to end because we're over a minute.
Right. No, I agree with you. We want to get infectious diseases in hospitals down because they are a tremendous problem and hardship. And on the medical malpractice reform, when they capped the non-economic damage awards in Texas at $250,000, a lot of docs who had left, OBGYNs and neurosurgeons, are now coming back into Texas because there's an environment there where doctors want to practice medicine. We've seen in states like Pennsylvania and Nevada where a lot of OBGYNs and neurosurgeons have left the practice of medicine because the cost of their med mal is so expensive that it's not profitable for them to practice medicine.
Thank you. Next is Ms. Baldwin.
Thank you, Mr. Chairman. Professor Reinhardt, I enjoyed some of the points made in the end of your written testimony that you weren't able to make in your more abbreviated oral testimony. One of the things that I'm interested in is the role, well, first your comment, you call it the electronic farmer's market. I think we're used to calling it the exchange or connector, but that entity would have to be empowered with regulatory powers to supervise and enforce the reputability of the products being offered. We've also had a lot of comments about having the inclusion of a public option. And in fact, Dr. Fader said a public system, I think I'm quoting accurately, a public system can keep the private system honest. So I'd like to hear your take on the interplay between the regulatory powers that are going to be necessary and having a public sector option sort of perhaps substituting for that or at least enhancing it.
Well, if you want to have any market, no matter what it is, has to be regulated. And we now find out, to our great dismay, that the market for credit default swaps also should have been regulated. So you need that. And in healthcare, with the insurance industry, it's still the Wild West in many ways when you come to the individual market. That's not true for the employment-based system. So you do need to be sure that these policies don't have fine print that ultimately leave you uninsured rather than insured. So you need regulation there. You then have to make a decision if you want community rating or not. If you say we allow medical underwriting, then the subsidies you give people have to be tailored to their health status, which is difficult to do. So I think such a body would by nature have to be regulatory, endowed with the power to regulate, or it goes back to government.
Dr. Fader, you address as, I think, your fourth point that you gave us take-home points that we have to stop discriminating against sick people in coverage. I want to hear your take on whether the high-risk pools that have been available as a tool to cover sicker populations, have they been a success story, a failure, somewhere in between? What's your take on that?
Congressman Baldwin, my colleague Karen Politz will be testifying on the next panel, and I will be drawing insufficiently on her expertise in answering the question. But I think high-risk pools are problematic. One, they pull off people from the rest of the system, and I think we would be better pooling risk everybody together. Second, they have been completely inadequately funded, charge the people who are high risk high rates so that many people who are sick can't get into the high-risk pool. Third, as I understand it, they impose pre-existing condition exclusions on people who are sick or high risk, which I'm laughing because that boggles the mind. So it is possibly true that adequately funded with good rules, it may all come together, and I urge you to ask Karen to tell you that, but as it has been treated, it is not a substitute for a well-regulated insurance market that everybody gets to choose a plan, regardless of health status.
And some states, the high-risk pools work better than in others, depending on funding.
Mr. Chairman, I yield back the remainder time.
Thank you. The gentleman from Connecticut, Mr. Murphy.
Thank you very much, Mr. Chairman. Ms. Pipes, I want to go back to this issue of wait times for a moment. I think we spend a little bit too much time obsessing over one system, the Canadian system, given the number of other examples. But one of the statistics that's often used is wait times for specific surgeries like hip replacements and knee replacements. And there certainly are longer waiting times in Canada for those procedures. For knee replacements, I think it's about 3 weeks in Canada, about 8 weeks in Canada, about 3 weeks in the United States. But what gets lost is that the payer for those surgeries in the United States is the government. Most often, 71, 70 years old is the average age for a knee replacement surgery. And in the United States, Medicare seems to do a pretty decent job at moving those people through the system and getting care at a more expedient rate than Canada does. And so I guess it's a way of asking this question. You sort of in your remarks seem to suggest that just an inherent flaw of a government system is longer wait times. But it seems that our experience with Medicare is that if you put the money behind the program, that if you make the choice to get people care faster, then a public system or a public plan could work just as well as a private plan could. So do you think that it's inherent in a public versus private dichotomy, or do you think that if you choose to spend the money and get the provider network and get the wait times down, that you could get wait times down in a public plan?
Well, in Canada, you could reduce the waiting times by putting more and more taxpayer dollars into the healthcare system. The problem is that Canadians are taxed at a much higher rate than Americans, and the government feels that where they are now, they're taxed enough. And, you know, I did work at the Fraser Institute in my early years called Tax Facts, where we developed the Canadian Consumer Tax Index and compared the levels of tax in Canada versus the United States. And we work on average 2 months longer because we have a lot more government in our lives in Canada. So, you know, in the case of my mother, who needed a knee replacement, and she was a senior, she waited 2 years to get a knee replacement. Then when they replaced it with a plastic knee because they said their actuarial records showed that at her age, she would only live for 5 years, and therefore the plastic knee was more efficient and more cost-effective. But, you know, she lived 8 years longer, and she was in severe pain. So, you know, this is how Canada, you know, controls costs, and people don't have access to Pap smears on a regular basis or PSA tests and things. We have a lot of prevention in this country, but these things are more expensive. But we have to decide in this country, you know, if you want a lot more government in your health care, you're probably going to end up rationing care because, as we've seen in Massachusetts, the costs have been a lot more than what the original estimates were.
I think we both use anecdotes on both sides of this debate, but I would say that your testimony has been peppered with stories about Canadian healthcare experience, and I'm just looking at the data on knee replacement surgeries that just don't back up that type of time frame. And I do agree with you that it's a matter of choosing to invest in the system. I mean, no one's talking about a United States healthcare reform proposal ratcheting down the percentage of GDP to what Canada spends today. We would love to control costs, but we're not going to spend as much as Canada does, and we're going to hopefully get a little bit more than they do. And which brings me to a question for Dr. Reinhardt. In your testimony, one of the things you talked about was the relative ineffectiveness of the private insurance system to get a handle on the cost of care in this country. And that's been a vexing question for me for years. With the private sector healthcare system has obviously immediate incentives to bring down the cost of care because it increases value for the company, for its shareholders, and doesn't have the burden that some government systems does of having to go through a regulatory process to try to change behavior. And yet, we don't have private insurers investing in simple preventative procedures and costs that could bring down care. Why do you think that our private healthcare insurance system in this country isn't doing as good a job as it could controlling costs and investing in prevention?
I think that's an extremely interesting question because in the 80s, a lot of us, myself, thought the HMOs actually could do exactly what you said. And there were proposals to make Medicare into a defined contribution plan because there was talk that an HMO, well-run private plan, could do the same thing Medicare does, much cheaper. Sometimes even people said 25%. So then we gave them 95% of the average actuarial per capita cost and said that's very generous. They should be able to shoot fish in a barrel, given Medicare is so inefficient, as everyone said. But they couldn't. As you know, in the 90s, they all pulled out. And the only way they seem to have made it work is to get that 14% extra. I find that very disappointing as an economist, that the private market that I usually believe in somehow failed us here. Why are they not more efficient? Why, for example, given Florida is a lot more expensive for Medicare than, say, Iowa would be, why wouldn't HMOs thrive in Florida managing care? I don't think they have proven yet that they can do it. I hope someday they can. But so far they have not. And it's a very intriguing question why they have not been able to reduce costs. And in the early decade, you know, premiums went up 14, 15%. And I always said, this is stunning. Medicare has nothing like these increases, and yet the private sector came with these increases.
We have to move on.
Thank you, Mr. Chairman.
Sure. Gentleman from New York, Mr. Wiener.
Thank you, Mr. Chairman. I think to some degree this discussion about public versus private plans, I think might be too, it's too binary a way to look at it. What does Congress have? I mean, it has a private plan, right? But we aggregate our many employees. We offer a phone book not dissimilar to the size of Mr. Shadeg's visual aid there, of different options, of different prices, of different types of service. What does the panel think Congress has in the language of this discussion?
You can argue that what Congress has is an example of a connector in the Federal Employees Health Benefit Plan. And for purposes of disclosure, I'm the wife of a federal retiree, so I have it too. And we choose, from those of us who have it, from a set of private health insurance plans. So what is being talked about when we talk is talking about adding a public health insurance plan to that menu.
And Ms. Pipes, would you two characterize what Congress has as a private model in the way you've described it?
Well, the Federal Employees Health Benefit Plan, of course, is part of the government, but they have private plans within that. And my understanding is that the Blue Cross sort of traditional plan still costs members of Congress about $400 a month. because I think the plan is about $1,200 a month, and it's
right, but mightn't there, forgive me for interrupting, but mightn't there be, I mean, look, I think we have a political imperative, and as we try to work this out, is to try to take that large percentage of American citizens who have health insurance that they're satisfied with, that would like to pay less, but keep them invested in this discussion. It's important that they be involved. But I also think that this notion that government involvement, the moment it touches this, creates a problem, and letting everyone go out and deal with this problem on their own, as Mr. Shadegg and you have suggested, goes too far in the other extreme. For example, what if you aggregated a whole bunch of businesses that were on their own not able to shop very competitively for health insurance plans, but you as the government, we as the government said, you know what, we're going to take 100,000 employees of small businesses in New York City, and we're going to go out and we're going to put a book together of different insurance plans who now, knowing they're getting 100,000 customers. And we're also going to do a couple of other things. We're going to say you can't consider you can't exclude people because they have pre-existing conditions. There are certain minimum standards that you need to have and the like. You're then kind of taking a little bit of the private model, a little bit of the public model, a little from column A and column B. Would you find that offensive to your notion that the government should not be involved in this?
Well, I was a very big supporter of association health plans. Association health plans, which would have allowed under a lot of smaller businesses to group together and then go into the market and negotiate better rates. So I'm a big fan of small business needs.
So you'd be fine with government putting its finger on the scale, having standards, having regulations, requiring certain coverage and the like, so long as the people writing the checks to the doctors were private insurance companies rather than the government.
Right, and I think we've seen, New York has community rating guaranteed issue. You have one, New York and New Jersey have some of the most expensive insurance plans because of those. I would prefer to see some of the mandates and things like that removed. I mean, if you want to get a plan that has community rating
I
guaranteed
understand.
issue,
I just have a moment more. Dr. Reinhardt, can I ask you a question that touched on what Mr. Murphy concluded with? Do you think that insurance companies in the present model intentionally do things to make money on the float? Do you think the reason there are 6 major insurance companies and they have 6 different forms, for example, is an example of them trying to build in inefficiencies that benefit their bottom line but make reimbursement slower, make it more difficult for doctors, more difficult for patients to navigate? Do you think they're trying to find ways? I mean, are they not incentivized by a different set of imperatives than perhaps Medicaid is? Maybe that's why the inefficiencies remain. I mean, you go into a hospital administrator's office and you see literally inboxes and outboxes for all the different insurance companies because, despite the fact they're asking for the same information, they intentionally keep that inefficiency in the system because they make money on it.
Well, I think if interest rates, short-term rates were 8-9%, I think you have a point there. In fact, I teach a course in financial management, and that was one of my lecture notes, how much you could make off the float by just dragging out payment. But with low interest rates such as we've had, I think it would be unprofitable.
No, I was thinking more of the structure, the way the industry has structured itself to have these inefficiencies, not just for the moment. Do you think that's why it evolved to be so inefficient and so lumbering very often, is because they make money on that? When you were giving that class in 2003 or 4, what were you, or 2000? Well, maybe that's too early. Yeah. 2005, what were you saying?
Well, I mean, there was definitely. I took a health plan in New York. And showed that basically they made most of their money on the float, which is, of course, not necessarily dishonest. That is part of an insurance industry's source of income, is to make money on the float. What was questionable is, did they deliberately drag out payment so that they could make more money on the float? And that's easily fixed by saying, if you don't pay within 30 days, you'll pay an interest rate. Just like in any trade credit in business, you could say, you pay within 30 days, that's fine. If you drag it out longer, you have to pay the hospital 1% per month. You drag it out. That would solve the problem, which is, in fact, what my class and I concluded could be done.
Thank you, Mr. Chairman.
Thank you. Chairman Waxman.
Thank you very much, Mr. Chairman. I've been listening to the discussion. I had to miss some of the earlier presentations, but I think this has been an excellent panel. Dr. Reinhardt, you've indicated you think that whatever we do, employer-sponsored insurance is shrinking, and it will continue to shrink, and that this may be a good time for us to develop an alternative for people, an alternative based on a reformed individual market, a public insurance program, or both. And that's been the basis of a lot of the discussion and debate. But I want to ask you, what should a health reform bill do to make sure that health care coverage is affordable for those who no longer have access to employer-sponsored coverage? Should we look at the amount of money that people pay out of their income for health? Should we try to say that you not just look at the premium, but all the out-of-pocket costs, and then say that people shouldn't have to pay more than 10%, 7% less or more of their income?
I think, Chairman Waxman, that would be the way to go. You have to focus on total health spending, not just premium, and then relate it to the ability of the family to pay for that. And that, in some way, is an ethical, political decision where you put those numbers. If you were to say somebody making less than $25,000, what should that percentage be? I personally feel 5% would stretch them already. While, if, as I said earlier, if it were someone like me, if you set that at 12%, I wouldn't cheer, but I think I could eat it, I could manage that, and it would be fine. And in the short run, bringing more people under insurance will cost money because they're not now, they're consuming less than half what insured people get. So we would have to top it off. And the estimates are somewhere 120 billion to 150 billion a year if you wanted really full coverage. But in the longer run, I do believe we can make healthcare in America a lot cheaper by doing the kind of cost containment candidates from both sides of the aisle had. Senator McCain also had ideas about cost containment, but they take longer to do.
Would you put a limit on the out-of-pocket expenses at, let's say, for low-income people, 5% of income? Would that make sense, given the cost of food, rent, and transportation? Would you try to figure out some kind of limit for those who have insurance and how much they'll have to pay out of their pockets?
I would absolutely try to figure out a limit. Now I'm shooting off the hip. I said 5% might even stretch people. I always wonder, as someone on the upper strata of the income distribution, I wonder how people on 25,000 family income make it. I used to be there. I grew up poor, but I forgot. So I think it's quite conceivable that 3% would stretch them. One would really have to budget this out, and that may be a good research project for Judy Fader to figure out. That's what you do.
Why, thank you.
Right.
In our spare time.
Whatever, I mean, obviously you can list what families need to spend on basics.
What is Ms. Pipes, what do you think about that? Do you think there ought to be some limit on how much people have to pay for their health care?
Well, we have people at 25,000 are obviously on Medicaid, and we have now an expanded state children's health insurance plan. So we've got a lot of government. I would like to see, as I've said, open up the market and change the employer-based system. Allow it to still be there, but if you tax the employer benefits and then provide a refundable tax credit for those people, and also then I think we would see the individual market expand, and we'd see new competition, new insurers, and we would.
Well, let's say we don't get what we want, and people still, to get an adequate insurance coverage for their health needs, have to pay so much out of pocket. Should we assume that they just made a deal that didn't work out for them and let it go?
Well, if you look at Massachusetts, which had the individual employer mandate in their Romney Care plan in 2006, I mean, even after the Commonwealth Care and the subsidized and free plans, you still saw that 20% of the people in the first year that should have bought insurance were excluded because the premiums were still too expensive. So it's very difficult for me. I don't know what the ideal number is, but
with the few seconds I have, I did want to ask you one other question.
Yes.
What would you think of the idea, and Mr. Weiner was sort of hinting at this, that people go to a connector and buy a a private insurance policy, but the connector be like the federal employees benefit package, where you have, in effect, a lot of private choices that are group plans, so you eliminate the discrimination and all of that. What would you think of that kind of a connector to private plans?
Well, I would support
private insurance plans.
Yes, I would support a connector if it was totally private. But when you have government politicians or government bureaucrats determining, what has to be on the insurance plan in the connector, then often I see price going up, and it becomes more difficult. So I would support a totally private connector, but I'm not in support of a national insurance exchange such as Mr. President Obama has been talking about, because I see the controls that would be set by government causing
So you don't see that
insurance
working.
to go up.
Dr. Fader, if we had that ability for people to go to a connector and buy a private insurance plan, do you think it could work like the federal employees, and do you think you need a public option to provide some tension to keep the private insurance plans affordable and all of that?
I think the combination is ideal. I think what we're looking for is we can think of it as a public choice plan, essentially we create a place, as you say, where people are able to buy a group insurance without discrimination based on health status. But to do that alone without a public health insurance option, we have not seen great competition, whether in the federal employees health plan or any other. So that having the public health insurance option, as I said earlier, can make the whole market work more effectively, because we can hold it accountable for delivering good benefits, delivering good care, and essentially working to negotiate good rates with providers.
Thank you. Thank you, Mr. Chairman.
Thank you, Chairman Waxman. And I think all of our members have asked questions, so I really want to thank you. This was a great panel. It was really thought-provoking in terms of our efforts to draft legislation and address the whole issue of health care reform. So thank you very much. We appreciate it.
Thank you.
Thank you.
And I would ask the next panel to come forward.
I'm exhausted.
96 cents. What? That's the current price of an AIG share. 96 cents. It's up 14 cents today.
Time to buy. Average down.
We already own it. Who does? The taxpayer.
Keep going.
Who do you want where?
She's showing us.
Where do you want us?
Is this the right order, or?